Greetings from Indian Journal of Anaesthesia. I'm Dr. Kiran Mahendru, IJA Vlogger, and I'll present an original article published in the March issue of IJA. It is a randomized controlled trial comparing video laryngoscopy versus conventional blind technique for transoesophageal echocardiography probe insertion in pediatric patients undergoing cardiac surgery, a pilot study. TEE has become a standard perioperative diagnostic tool during pediatric cardiac surgeries, and the insertion of TEE probe may lead to pharyngeal and esophageal injuries in pediatric patients undergoing cardiac surgery. In the anesthetized patients, the incidence of oropharyngeal injury due to insertion of TEE probe is from 0.2 to 1.2%, and the incidence of orogastric tract perforation is 0.01 to 0.09%. Conventionally, the TE probe is inserted blindly in patients under GA, and difficulties may occur in directing the probe tip into the esophageal orifice during insertion by conventional technique, which may result in oral and pharyngeal injuries. And we know that video laryngoscopes have been shown to improve the laryngeal view and the rate of successful tracheal intubation. So, with this, the study was conducted with the primary objective to observe the incidence of oropharyngeal injury after TEE probe insertion using two different techniques, that is, the conventional blind technique versus the video laryngoscope guided technique in pediatric patients undergoing elective cardiac surgery. The secondary objectives were the number of attempts required for successful TE probe insertion, the duration of insertion, and the relationship between the laryngeal and esophageal inlet. The hypothesis of the study was that video laryngoscope they provide direct and better visualization of esophageal inlet, and its use may reduce the incidence of injuries related to TE probe insertion as compared to the conventional blind insertion of the TE probe. Ethical approval was attained. The trial registered with CTRI. It is a single center randomized intervention study conducted from March 2024 to September 2024 in pediatric patients from 2 to 10 years of age undergoing elective cardiac surgery, which requires TEE evaluation. Patients with deranged coagulation profile, sore throat, difficult intubations, trauma during intubation, and contraindications to TE probe insertion were excluded. Randomization was done using computer-generated table sequences. Conventional group was taken as group C, and the video laryngoscope group was group VL. Two cardiac anesthesiologists with more than 3 years of experience in perioperative pediatric TEE participated and inserted the probe in the study population. The standard ASA monitors were used, and induction was done using midazolam, ketamine, fentanyl, and vecuronium. The conventional Macintosh laryngoscope of appropriate size was used to secure the airway with an appropriate size cuffed endotracheal tube. The nasal temperature probe was inserted, and the maintenance of anesthesia was done using fentanyl, vecuronium, and sevoflurane with oxygen. In the conventional group, the group C, a pediatric TEE probe was inserted using conventional blind technique. The TE probe was inserted in a neutral head position with the right hand through the midline while gently lifting the mandible forward and putting the thumb of the left hand into the mouth of the patient. In the group video laryngoscope, that is VL, a Macintosh type non-channeled video laryngoscope with a 66-degree viewing angle was used to insert a pediatric TEE probe. The VL blade was inserted orally and advanced to the epiglottic vallecula. The esophageal inlet was evaluated, and the TEE probe was advanced into the esophagus under the direct vision. Now, this is the figure showing the insertion of a pediatric TEE probe using a video laryngoscope. The TE probe was removed after the surgery, and all the patients were examined using a video laryngoscope for oropharyngeal injuries. The injury sites were documented and recorded with the help of an image which was captured through the video laryngoscope. Trauma during TE probe insertion was defined as an evidence of physical injury to the oropharynx or esophagus, causing abrasions, tears, bleedings, or hematoma visible on video laryngoscopic examination at the completion of surgery. The number of attempts to insert the TE probe and the duration of probe insertion was also documented. If more than 3 attempts were required to insert the TE probe by either of the technique, the patients were excluded from the study. The duration of TE probe insertion was defined in the conventional group as the time from opening of the mouth to insertion of the TE probe into the esophagus and obtaining a mid-esophageal four-chamber view. In the video laryngoscope group, it was defined as the time from opening of the mouth for insertion of the video laryngoscope to the time of obtaining the mid-esophageal four-chamber view after insertion of probe into the esophageal inlet. A blinded anesthesiologist examined the photographs of the video laryngoscope to determine the relationship between the esophageal inlet and the larynx. The primary outcome of the study was to observe the incidence of oropharyngeal injury after the TE probe insertion using two different techniques in pediatric patients undergoing elective cardiac surgery. The secondary outcomes were the number of attempts required for successful TE probe insertion, the duration of insertion, and relationship between laryngeal and esophageal inlets. Due to unavailability of literature on the incidence of injury caused by TE probes in pediatric patients of this particular age group, the study was conducted as a pilot study with a minimum sample size of 50 patients in each group. SPSS version 20 was used for statistical analysis. A total of 120 patients were assessed for eligibility and 20 were excluded because of predicted difficult intubation in 8 patients, not willing to participate in 9 patients, and trauma during intubation in 3 patients. So, a total of 100 were randomized with 50 patients in group C and 50 patients in group VL. The demographic characteristics of the patients included the age, weight, body surface area, gender, and the CL grades. Now, this is the table showing comparison of the two groups for the incidence of injury, attempts, and the duration of probe insertion. Now, coming to the incidence of injury, which was the primary outcome, as you can see, in group C, the conventional group, injury was noted in 9 patients, whereas in group video laryngoscope, the injury was noted in only 2 patients, that is 4% of the patients. And this result was statistically significant with a p-value of 0.025. Now, coming to the attempts of probe insertion, as you can see from this data, only 2 patients, that too in the conventional group, required 3 attempts for the TE probe insertion. In the single attempt, the probe was inserted in 84% of the patients in the conventional group and 96% of the patients in the video laryngoscope group. Now, coming to the duration required for successful TE probe insertion at a first attempt, you can see much less duration of time was required in the conventional group, which was 18.55 versus the video laryngoscopy group, where the duration for successful TE insertion was significantly higher, that is 28.75 in the video laryngoscope group when compared with the conventional technique of TE insertion. Now, a subgroup analysis was done by dividing the patients into 2 to 5 years and 5 to 10 years. Now, incidence of injury in the two subgroups were compared. As you can see in the conventional group, the incidence of injury was higher in 2 to 5 years of age group, was seen in 6 patients as compared to the 5 to 10 years of age group. In only 3 patients, injury were noted in the conventional group. Whereas in the video laryngoscopy group, the incidence of injury was equal in both the age groups of 2 to 5 years and 5 to 10 years, and the results were not statistically significant. So, the injuries in the conventional group were significantly more in comparison to the video laryngoscope group on VL examination after TE probe removal. Now, this is the figure showing the injuries seen post TEE probe removal in the study. The probe was successfully inserted on first attempt in 42 patients, that is 84% of the patients in the conventional group, while it was successfully inserted in first attempt in 96% of the patients in the VL group. The mean duration for successful TEE probe insertion at first attempt was significantly higher in the video laryngoscope group, that is 28.75 seconds, compared to the conventional group, where the time required was 18.55 seconds. Now, TE probe insertion using a video laryngoscope results in a higher success rate for probe insertion on first attempt and causes significantly fewer oropharyngeal injuries. Now, patients under GA with endotracheal intubation have loss of swallowing reflex and pharyngeal space collapse, leading to difficulty in insertion of TE probe. And also, these patients are unable to respond to in case of injuries caused by the TE probe. Now, advancing the TE probe by directly visualizing the esophageal inlet using a video laryngoscope and insertion into it may avoid oropharyngeal injury. Now, the authors have compared their studies with the different studies which were conducted in adult patients. Now, in the present study, they have taken 100 patients from 2 to 10 years of age undergoing elective surgery, where they have used conventional group versus the video laryngoscope group, and they have found a statistically significant success rate of insertion at first attempt with video laryngoscope. The injuries were statistically less in video laryngoscope compared to the conventional group, and the total duration of insertion was higher in the video laryngoscope group as compared to the conventional group. Now, coming to this study by Osterk and Kawalki et al., 86 adult patients were taken undergoing cardiovascular surgeries, where the patients were divided into conventional group and the McGrath group. Now, as you can see, the success of insertion at first attempt was also statistically significantly higher in the McGrath group as compared to the conventional group. Injury, as seen by blood presence at the tip of the probe, was also higher in the conventional group. The pharyngeal injuries were also higher in the conventional group. And when comparing the total duration of insertion, the total duration of insertion was higher in the McGrath group as compared to the conventional group in this study. Now, a study by Bode et al. Included 363 patients from 18 to 70 years undergoing elective cardiac surgery, where groups were divided into conventional and video laryngoscopy group. The success rate was also significantly higher in video laryngoscope group as compared to conventional group, and injuries were less in video laryngoscope group as compared to the conventional group. Similarly, a study by Teboda et al. In 100 intubated critically ill patients comparing conventional group with video laryngoscope group. The results were similar to that of Bode et al. That is, a higher success rate of insertion at first attempt using video laryngoscope and less incidence of injuries. Ishida et al. Studied 100 patients undergoing elective surgery, where two groups were Macintosh versus McGrath group, and the results were statistically significant higher success rate of insertion at first attempt using McGrath group, and the injuries were also less in the McGrath group, and the total duration of insertion was higher in the Macintosh group when compared to the McGrath group. Now, the relationship between the laryngeal and the esophageal inlet may not always be anteroposterior, and this can also lead to difficulty in inserting the TE probe using the conventional technique and result in the injury. Verma et al. They observed an increase in the endotracheal tube cuff pressure during insertion of a TE probe and a reduction in the tracheal perfusion pressure in pediatric patients undergoing cardiac surgery, and they recommended monitoring the cuff pressures to avoid possible airway complications. However, in the present study, the cuff pressures were not monitored. Now, the limitations of the study: the authors did not follow up the patients in the post-op period to assess the occurrence of odynophagia and dysphagia after surgery, assessed complications related to probe insertion, but did not assess other injuries related to repeated manipulations and thermal injuries. The sample size may be too small to study serious complications like esophageal gastric perforation, which often necessitate evaluation and additional interventions. They did not examine the nasopharyngeal cavity before placing the TE probe. They did not grade the trauma caused by TE probe insertion or observe the hemodynamic response during insertion of the TE probe. It was a single center study, and they examined the oropharyngeal cavity as well as the laryngeal and esophageal inlet using the video laryngoscope. But there was no fresh injury or bleed which can be attributed to video laryngoscope in the study. But there are still chances of some occult injury which cannot be ruled out. Therefore, to conclude, using a video laryngoscope for TE probe insertion in pediatric patients significantly reduces the incidence of pharyngeal injury related to its insertion and the number of attempts to insert the probe successfully. Video laryngoscope, it provides direct visualization of the esophageal inlet, and therefore the current study suggests that using a video laryngoscope to insert a TE probe should be a regular practice. Thank you.